So Keith, I know we've done this once, but still, like, can you like introduce yourself for the audience?
Sure, and thanks for having me for this again, Eric. So my name is Keith Barr. I'm a professor of molecular exercise physiology. I'm usually at the University of California, Davis, but right now I'm on a sabbatical year in Maastricht in the Netherlands, where I'm working with Luc van Loon, looking at how different types of feeding affects the production of collagen in tendons.
Nice. So, um, the first thing I want to ask is like, I know we used to discuss like tendon pain a lot, but recently I just found out like if some athletes have like tendinopathy, they may not have pain. So how
Yeah.
do we know like do they have tendinopathy or not?
So tendinopathy is simply a combination of two things. It's tendinitis, which is tendon pain with inflammation. So that's acute tendon pain. It's when you overdo it really, really recently, and you get an acute inflammatory response. And then you've got tendinosis, which is long-term. Basically, what happens is that there's degeneration of the tendon, and long term, there's not really signs of inflammation in long term tendinosis. But tendinopathy basically incorporates both of those types of things. So in humans, normally the way that we decide whether somebody has a tendon problem is because they have pain. Um, we know that pain is very different than structural differences. So if we look in basketball players, we're going to find that approximately, well, more than 85% of them are going to have imaging based signs of tendinopathy. So they're going to have tendon problems specifically in the knee. And that's work from Jill Cook looking at some of the Australian basketball players. But not all of those people are going to be symptomatic, which means that not all of them are going to feel pain associated with it. And so this is why the tendon field is a little bit problematic, and it's because our primary outcome is pain. If we decrease pain, the effect our treatment has worked, but we don't know whether we've actually fixed the problem. And a lot of people just think that you can't fix the problem, so we're just going to treat the pain. But what our recent work has shown is that we can fix the tendinopathy. We can fix all of the things that you can see with your imaging and get that tendon working perfectly again or near perfectly again. And so that's an important difference that comes with the idea of tendinopathy versus in kind of structural changes to the tendon versus pain-based changes within the athlete.
Cool. So, is there any way besides uh, like X-ray or other like, images, so we can tell, or examine the tendinopathy or like the
Yeah.
degeneration of tendon?
So right now, our best kind of absolute measures of tendinopathy are going to be MRI, where you should see a tendon should be completely black. There shouldn't be any white striping within it, or there shouldn't be any white within the core, or there's going to be ultrasound based methods. And so those can be ultrasound based methods where you're just looking at the overall structure, you're looking at the thickness of the tendon, you're looking at the structural orientation of the fibril level, not necessarily fibril level, but the fascicle level collagen and the alignment of the collagen. And so those are the two kind of gold standards that we would use for imaging. But a lot of people who have tendon pain don't necessarily see anything on injury on imaging either. So this is where the issue comes in, is that we've got this we've got this really common problem where people feel pain in a tendon. Sometimes we can see imaging based stuff, and other times we can't, even though the pain is equally real. And so in certain cases, like an acute overuse injury, where say it's the first nice day of spring, and you go out and you're gonna hit golf balls or tennis balls, and then you come back and oh my elbow hurts here, and or oh my elbow hurts here. Okay, so those things we're probably not going to see, like imaging based, we're not going to be able to see anything with our imaging. But if you're, a high level basketball player and you say, oh, I got pain in the front of my knee, right, or just under my kneecap, okay, there's a greater likelihood we're going to see stuff on imaging there. And so again, that makes the field a little bit more difficult, because if our primary outcome is, oh, look, the pain has gone away, we don't know whether, first of all, there was a structural injury in the first place, or whether it was just some inflammation. And second of all, we don't know whether we've actually changed, reoriented, and restructured that injured area just by decreasing the pain associated.
So if sometimes they have pain and we can't see it on images, how can we know how severe is it, or like how should we treat it?
So, so it's a great question, and so the first thing that we want to do is we're gonna look at our athlete as a whole athlete. So what you have to do is you have to look and see what their structured training is, what their gameplay, what their structured training is. If they're an athlete who's a basketball player, a volleyball player, somebody who's a jumping athlete, and even when there's no pain in the knee, we should be doing things that are designed specifically to increase the health of the knee. Because we know that the primary injury that we get in these jumping athletes is going to be jumper's knee or patellar tendinopathy. So what we're going to do is we're going to do some prehab. So we're going to do a little bit of training that is designed specifically to make sure that if there's any problems within the patellar tendon or the quad tendon, we are going to be getting those things initially before they actually develop into a bigger problem. If we've got a runner who's a 4 foot landing runner, we are going to look and we're going to do some Achilles tendon prehab, where we're going to do some Achilles work, because we know that if you're landing on your 4 foot and you're a runner and you're going to do lots of high intensity work, the likelihood is that over time you're going to get problems with the Achilles tendon. We can facilitate, we can improve your adaptations by doing some prehab work. So what we're trying to do is we're trying to look at our whole athlete, and we're not trying to say, look, we're going to come in, it's for you, it's going to be November, so you're working in basketball in the NCAA, so November is the start of practice, and so you're going to come in, you're going to have people doing 2-a-days, you're going to ramp up intensity, and you're going to put in a lot of volume. Well, what I'm going to do is I'm going to say, look, our volume is going from here to here, massive increase. Now, what we need to do is we need to do a few protective moves. We're going to have a lot of people coming into the athletic trainers saying, my knee hurts, or this hurts, or that hurts. And so what we're going to do is we're going to work within the structured program that is our training, so our practice time and our game time. And we're going to add in little sessions that are specifically designed to prehab to improve the quality of the tendons. And I'm going to do that even before they come in for 2-a-days. So I'm going to be doing that in the weeks and months coming in. I'm going to make sure that even though it's their off season, I'm not going to have them completely not using those tissues. I need to make sure that I'm giving those tissues the stimulus to maintain the stiffness, strength, and size that they developed over the last season. So if I just say, and this happens most commonly in baseball players, they're going to take baseball players and they're going to say, okay, season's over. Now I don't want you to throw for 3 months. Okay, so now I'm not going to throw for 3 months. Now the issue we're having is an ulnar collateral issue. So what we're going to do is we're going to rest everything, because rest is good. Well, rest is actually very bad for these tissues. Rest is not what we want. What we want is we want controlled loading through those tissues. And what we need to do is we need to make sure that we're maintaining at least some stimulus through that UCL in order for us to maintain the structures that we've built up over the season. Do I need them to go out and throw a ball thousands of times? No. I can do that by doing simple exercises that are designed, one, to get a load through in a very controlled way, and then two, to get a load through it in a very dynamic. And by doing that, what I can do is I can give the stimulus that the tendons need in order to maintain the structure, the size, the strength that they've developed during season, but without this huge mechanical load and this huge mechanical fatigue that they get from throwing all the time, that get from doing thousands of jumps all the time. And so what we're trying to do is we're trying to maintain in the off season, we're trying to maintain tissue structure at using what we call a minimal effective dose of exercise. Because what the idea of a minimal effective dose of exercise is that it's going to give me a signal to the cells within the tissue I'm trying to target that those cells need to still do what they were doing before, produce collagen in a directionally oriented way so that we can have a big, strong tissue. But it's a minimal effective dose. So it's enough to give us that signal without getting lots of mechanical fatigue. So if I have a pitcher who's throwing 300 times in a day, that 300 times, the first, say, 5 to 10 minutes of those throws, and depending on your frequency of throwing, that could be as little as 40 throws. That's the signal that my ulnar collateral ligament needs in order for the cells to know, oh, there's a throwing signal here, and we're doing this, and so that we need to create a structure that's strong here. So if I do that in 40 throws, but then I still throw 260 more times, each of those subsequent 260 throws is giving me a mechanical fatigue without giving me a signal to make the tissue better. So what it's doing is it's wearing down the tissue without giving me a signal to adapt better. And so what we get into is we get into an imbalance between the signal for adaptation and the structural or mechanical fatigue on the tissue. So we wear down the tissue. And that's extraordinarily common.
Does that mean that even without, let's say, isometric training, we still can like we still can stimulus our body or stimulus the cell to do collagen resynthesize?
Yeah, absolutely. So basically, if I've got a perfectly healthy tendon and I lift a heavy weight, what I'm doing is I'm giving the cells within that perfectly healthy tendon, because all we're doing is we're stretching it. And because it's a heavy weight, we're going to do it slow. It's going to be a slow movement. And that means that the load within the tendon is going to be relatively evenly shared. Okay. And so as I do that heavy lift, I'm going to go down, I'm going to do my dynamic lift, say I'm going to do a squat because I know I've got jumpers here. So I'm going to do my nice controlled heavy squat. That's going to give those cells within the patellar and the quad tendon great stimulus for adaptation. You don't have to do 4 million of them. You can do, say, 2 or 3 sets of 10, perfectly good stimulus to give me a quad and a patellar tendon stimulus to get a signal that they need to stay big and strong. Totally fine. I don't need to have thousands of loads go through there, and I can do it with a heavy strength training method. If instead of having a perfectly healthy tendon, now I've got areas within the tendon, like most athletes will have areas within the tendon that aren't necessarily as good because there have been some, because they've overdone it at some point, they've got a little bit of structural damage. Now, those cells and those parts of the tendon, they're not going to normally get loaded when we're doing our jumping and our normal activities. So if I have a UCL and I'm a thrower, every time I throw, it's such a high velocity movement that ulnar collateral ligament is really, really stiff. And what happens is when we move really quickly, that the load will go through the healthiest, stiffest parts of the tendon or ligament. Okay. And what happens when we have any kind of injury is that the injured area becomes less stiff than the rest of the tissue because there's been breaks within the collagen. And you can imagine that collagen that's not as structurally oriented isn't as strong and as stiff as the ones that are. So now what I've got is a combination of ones that are not very strong and they're not very stiff, and then ones that are strong and stiff. So when I do that throwing motion and I pull that ulnar collateral ligament, because the not stiff is in parallel with the stiff, when I pull hard on it, the load goes only through the stiff part. Okay, and it doesn't actually get in and start to help us fix those areas that are scarred or not stiff. That's called stress shielding. And that's the thing that causes scars within tendons or ligaments. And we know that because there was a Japanese group led by Professor Hayashi who basically just took a wire and put the wire from the patella of a rabbit to the tibial plateau of the rabbit, shortened it, and took a perfectly healthy patellar tendon, took the load off of it using a metal wire. And when he did that, what happened is that perfectly healthy patellar tendon, it increased the number of cells, it decreased the size of the collagen, and it decreased the orientation of the collagen. Those three things are the three things that we use to say that's a scar. A scar is an area of tendon or ligament with lots of cells, with small collagen molecules, and those small collagen molecules aren't aligned. And as a result of them being small and not aligned, they're not as strong and stiff. So now when I go to pull, the stuff that's not as strong and stiff doesn't get any load because the strong part is taking the load. So what we have to do special in that situation where we have a small area of damage is now what we have to do is we have to load it in such a way that the strong part of the tendon begins to relax a little bit. And here you can use dynamic moves, heavy strength training, heavy eccentric training. Those two things can work because what happens when I lift a weight that's heavy is by definition, my velocity of movement goes down. That's the force velocity curve. So if I try and move a heavy weight, I'm going to go at a lower velocity. When I go at a lower velocity, the tendon actually begins to relax and it goes through what's called stress relaxation. The same thing is true with eccentric loading. Eccentric loading, I can put a lot of weight on there because I'm 1.8 times stronger in the eccentric than I am in the concentric, but it's not a fast eccentric move. A fast eccentric move is not going to fix your tendinopathy. In fact, the guy who developed one of the guys who developed the eccentric loading protocol was actually trying to rupture his Achilles tendon. So Alfredson, when he first did it, he knew that people who ruptured their Achilles tendon and then fixed it tended to have less pain associated with the Achilles than people who had a partial tear. So what he did was he said, okay, he was a physiologist. He said he had problems with his Achilles, and it's like, oh, well, I'm just going to rupture it. And so what he tried to do is he tried to use lots and lots of weight to rupture the Achilles, but he didn't do the negative component of the lots of weight, which was the really fast. So he did it really slowly, and he started to realize that, you know what, my tendon is getting better. And so that was the generation of the Alfredson protocol, of the eccentric protocol. If he had done it the way that is damaging. So he had done the same super heavy weight, but did the eccentric load really, really fast. Sure enough, he probably would have popped it. And then we wouldn't have the Alfredson protocol. But because he chose to do it slowly, in doing it slowly, he got stress relaxation in the tendon. Because he had a heavy weight, we got load through the scar because the healthy part was starting to relax. So both of the things that I just told you, heavy strength training or heavy slow eccentric training, the component that's really important is the speed, the slow. And so when we look at it that way, then the slowest of all contractions is an isometric contraction because there's no movement. And so the idea is that if we take what we've learned from heavy, slow resistance exercise and the Alfredson protocol of eccentric loading, and we realize that the key parameter is the velocity. And the velocity is important because it allows, if we go at a low enough velocity, it allows stress relaxation in the tendon of the healthy part. Then the logical next step is to go to the slowest possible contraction, which is an isometric contraction, which is just holding a heavy weight at a specific length. And what happens is that as you do that, the stiffness within the healthy tendon goes down, and it actually goes down to a point where now the scar is stiffer than the healthy part. And now the scar actually gets the tensional load that we're trying to get through it to give it the signal to regenerate. And so that's why we use isometrics. That's why you can use eccentrics, you can use heavy strength training. It's just when you understand that the key component of all three of those is the velocity of movement is as slow as possible, then it's easy to say, okay, that if velocity is the most important thing and I want my velocity to be as close to zero as possible, that's when we say, well, isometrics are going to probably be one of the best ways to achieve that.
So just to clarify, I know some coaches gonna discuss this about like, is it the tension or is it the speed? So it's the speed. It's actually not the how high the tension is. Am I
It is
right?
not how high the tension is. And I can tell you that for certain because we've got a study now where, so we've done this using our engineered ligaments where we make little human ligaments in a dish and we can do it that way. And, but everybody's going to say, well, that's not a real person. But what we came up with there is we came up with about 10 minutes of activity is what you need. And we saw that it wasn't frequency dependent. So that meant that it didn't matter whether you did 10 in a second or you did one in a second, same stimulus. And we showed that it didn't matter whether you did a huge load or a small load. And so that's where the tension comes in. And so we had published this as a this is the best way to work your tendons as a review in sports medicine. And there were two professional climbers who got a hold of the rock climbers who got a hold of the article and they said, well, if this is true, then if I wanted to make my fingers stronger, the tendons in my fingers stronger, I don't have to hang with tons and tons of weight. And so what they came up with is this partial body weight hangs where they would just put a little bit of tension on their fingers. And they would do that for 10 minutes. And they would either do that once or twice a day. And so this is the brothers of the Abraham's brothers, Abrahamson brothers. And so basically Emil and his brother are professional climbers. Emil is also big on YouTube, so he did a YouTube video about it. That YouTube video is seen by about 1 million people now. And what we then did is we went into one of the most popular climbing apps and we looked for people who used these partial body weight hangs, or what we call now Abrahangs, or they used max hangs, where they used the maximum possible weight. And this gets directly to your question of, does it matter whether the weight is super, super high or not? What we found is that compared to climbers who just climbed outdoors on walls, bouldered, whatever, there was no increase in their finger strength if you were just climbing. If you did the Abrahangs, you got about a 2 to 3% improvement in finger strength. If you did max hangs, you got a 2 to 3% increase in finger strength. There was no difference between the two. The most interesting thing, so that what that tells us is that the load doesn't matter. It doesn't matter because partial body weight gave us the same response as your body weight plus extra weight. So that takes us away from this idea that the load is really important. The most interesting thing is that when you did both the Abrahangs and the max hangs together, you got an additive effect. And so what that likely means is that there's one thing happening to the tendons where we're fixing that with partial body weight, and that's totally good. But then if you really want maximum performance, you got to practice maximum performance because there's neurological components, there's muscular components. And so when you do both things together, you do a tendon health-based movement together with a neurological and muscle-based movement that are going to maximally activate the muscle and the nerve. Now what you get is you get an additive effect where the two things have a better effect than either one alone. But for the tendon, there's no difference max hang versus a partial body weight hang. So by extension, if we're going to come in and we're going to be working with basketball players or volleyball players who have jumper's knee, I know that all I really need to do is get time under tension. So about 30 seconds of time under tension where I can let that stress relaxation happen. And it's not an overall time under tension because we've actually done this in the laboratory where I had a great PhD student, Danielle Steffen, and she produced a rat model where we put a hole into the patellar tendon, just like you would see in a basketball player. And then 2 weeks later, once it had formed a tendinopathy, we then loaded it using 4 isometrics that lasted 30 seconds. So the total work time was 8 minutes. Or we used the exact same amount of time under tension with dynamic moves. So it was 360 dynamic contractions over that same 8 minute period. When we looked at the tendons at the genetic level, the ones that did the four isometrics had all of these tendon like genes go up. Whereas the ones that did the dynamic contractions, they actually didn't see the increase in tendon genes. And we actually saw increases in cartilage genes. And that was just because as we pull really hard and really dynamically on a tendon, if there is a hole in the middle of the tendon, that hole actually gets compressed as we stretch the tendon. This is what happens in a lot of basketball players and a lot of volleyball players because they're jumping all the time. So they're jumping all the time. They get a small defect or a small injury to the center of the tendon. And now as it pulls, because the tendon is isovolumetric, as it gets longer, it has to get skinnier. Well, the healthy parts are on the outside. So we're loading the healthy parts on the outside. They're getting a lot of tension through them. And as they get that tension through them, they actually come together because there's no resistance in the middle. And so what we get is we get compression of the core and we actually get cartilage. And that's why on an imaging modality like MRI or ultrasound, we can see a hole. Because what we've done is we've changed the tendon into more like cartilage like cells in the middle. And that's something that we can see. And that's why the isometrics are important because when we do that pull, isometric hold, now what happens is those outside relax, the center begins to feel tension because the center, the injured part, now feels tension because it becomes stiffer in tension than those outside parts as they relax. And now we've given the signal that we need for those cells within that scar to become tendon again. And we've been able to regenerate tendons from elite athletes like NBA players, like track athletes, all kinds of different athletes who have these central core patellar tendinopathies simply by using this stress relaxation.
So I know I asked this before and kind of talk a little bit about it. Does that mean that when it comes to like isometric for tendon health, does it have to be like 30 seconds? Can we go a little bit shorter, like 20? Does that also gonna like
Yeah,
increase collagen resynthesis?
yeah. So basically, a lot of it depends on how much adaptation you've made. So if you've got an athlete who's a high level athlete who's been training and they're honest with you and they say, look, I've had this knee pain for 5 years. A lot of times what's happened is they've had so much compensation in the other tissue that that other tissue is really, really strong and stiff. And so for us to get a signal to the injured part, we need a long time under tension. For somebody who does something, they don't have a history of tendon problems, they maybe tweak a little bit of something, then using a shorter period is fine. And I've told you that even doing heavy strength training or slow eccentrics is going to give us some stress relaxation. It's just not as much. The reason we settled on 30 seconds is because the relaxation in the first 30 seconds is about two-thirds of what we would get if we waited 2 minutes. When we look and we do all the different possible combinations, and again, this is work that Daniel Steffen has done, the best response that we get is actually when we go for a minute. Because again, we're getting greater amounts of stress relaxation. The longer you go, the more stress relaxation of the healthy part, the more load we get through the injured part. A lot of people have a hard time going for a minute. Totally understand that. But what we can see is that if we go for 10 seconds, we're going to get some effect. If we go for 20 seconds, we're going to get a better effect. 30 seconds, a little bit better. Out to about 30 seconds to a minute, maybe there's a small benefit of the minute over 30 seconds, but the effect size goes down. So if we go a 3 second isometric is going to be better than a dynamic movement. It's a 10 second is going to be better than the three, and we can get, and then we get to about the plateau about 30 seconds. And that's really why we've chosen 30 seconds.
Nice, nice. So, uh, we also discussed about like some tendinopathy, they may not have pain. So, if if like uh an athlete or a client who has like seriously really bad tendinopathy, uh does it do we can't like get them back from like ISO or like heavy eccentric?
Yeah, so in our published paper with the professional basketball player, there was a significant hole in the guy's patellar tendon. So he had a big hole that you could see on the MRI, no problem. Within within in that case, the next MRI we took was 12 months later, and it was almost completely gone at 12 months. Okay, we've also done it with a discus thrower who was an Olympic discus thrower. He did it, and the reason I like that example is because he looked at it using ultrasound, and he saw, look, there's a big hole on the ultrasound. He did the isometric training for, in his case, 50 days, went back, got an ultrasound. He was pain free after the first 2 weeks, but then he went back after 50 days to get another ultrasound, and the hole was completely gone after 50 days. And the patellar tendon itself was significantly thicker. So what this tells us is, it tells us that, there's this idea that we treat the donut, not the hole, because it's easier to get the donut, or the healthy part of the tissue, the part that surrounds the injury. It's easier for us to get that to be stronger than it is for us to fix the core. And that's fine. That'll get you through a lot, but it's not going to make that tissue better. And then if there's periods where you go through a period of inactivity, or you go through a period where you don't load it as much, what's going to happen is your tendinopathy is going to come back. So what we're trying to do is, we're trying to say, look, we can fix that. We can fill in that donut. We can make it a whole tendon again. We just have to do these type of long isometric holds that are a little bit, that are heavy enough to give us stress relaxation within the healthy part. And we just need to do that for a concerted period of time. And that looks like it's about 5 to 6 weeks is enough to have really significant changes to the structure of a tendon. And it doesn't take a huge amount of time for that to happen. Already within 1 to 2 weeks, we've already decreased pain dramatically. It's just a matter of, now as you go out to 5, 6, 8 weeks, now what you're doing is you're just making it so that the tissue is becoming more and more healthy again, so that you're regenerating that injured part of the tissue.
And we can actually make the tissue stronger, but
Absolutely.
stronger
That
than
we,
before.
yeah, absolutely. Absolutely. Especially if it was an injured tissue. And even if you have people who aren't injured, what our rock climbing example is showing is that if we combine performance-based moves, so things that are going to give us strength, so give us neural activation, give us a big force, a load stimulus. If we combine that with a healthy move that's a partial body weight, where we're only going to get the signal that the cells need to get adaptation within the tendon, now what we get is we get an additive effect. And so, really, what this is telling us is that and this is true for a lot of different training, we know that if we combine different types of loads, we actually can see additive effects. And especially if one of those is designed to be a healthier load, so a heavy, slow load, and the other is designed to be a performance load, so something that's more at either at the max force or at max power. So if we combine those two things, we see it within the gym all the time. Understanding that what we're getting is, we're getting two different types of adaptation. We're getting one type of training that's giving us adaptations within the tendon. The other type of training is giving us adaptations within the muscle, but also within the nervous system, and the ability to activate those muscles. But if I can activate the muscles and I've got great muscle strength, what but I have really crappy tendons, what I'm going to do is I'm going to injure myself. And we know that from all the guys in baseball who used to use testosterone. Testosterone, what did it do? It increased aggressiveness, so that their neural activation was really, really high. And it increased muscle mass, so that their muscle mass is really big. And now you've got big old muscles and great neural activation, and you've got crappy tendons, because testosterone actually decreases collagen synthesis and makes your tendons stiffer. So it makes your tendons brittle. So what happened to all these baseball players? Performance went way up. And then what happened? Performance went way down, because they all got these incredibly bad musculoskeletal injuries. And in fact, a lot of statisticians can go back without knowing anything about the baseball player, and they can look at their pattern of performance and say that guy was using steroids because their performance went up for a short period of time and then it went away because they got injured. And that tells us a huge amount about what's going on. It tells us that we've got to understand that, look, neural activation and muscle strength, that's great, but you need to have tendons in order for us to actually have a system that works.
Nice, nice. That's awesome. So, do you, is there a model or is there a continuum so we can know like how severe is the tendinopathy or how severe or where is it at?
Yeah, so what we find is that tendinopathy is going to produce a lot of, so what our most consistent finding is that a tendinopathy produces a small, what we call strength gap within the range of motion. And so this is something that the athlete can't really hide. And so this is how we look for tendinopathy. So what I'm going to do with an athlete, if I've got an athlete who says, "Oh no, I never had any knee pain," okay, that's great. So now what I'm going to do is I'm going to take you to like a leg extension machine, and I'm going to have you do two-footed leg extension, and then I'm going to have you take that weight down with one leg. And if you've got a perfectly healthy tendon, you're going to be able to slowly take that down perfectly without ever having kind of a hole in your strength. And what I'm going to see if you've got tendinopathy, you're going to get to a certain angle. And then what's going to happen is the weight's going to drop really quickly. And what we're seeing there is that now what we're getting is we're getting feedback inhibition because basically you've got a Golgi tendon organ that's trying to sense the tension within the tendon. And what that does is it protects the tendon from injury. As we go through a range of motion, if we've got an area where we've got a weakness within that tendon, what's going to happen is the load is going to shift away from being equally distributed throughout that tissue to only being in a small area. When it does that, it's going to give us a really quick signal to that Golgi tendon organ that, oh, tension just went way up. And so what happens is we drop the leg because we get actually inhibition of the quad muscle, so that because the Golgi tendon organ has feedback inhibition, it's a direct reflex that's going to block the quad with the idea that, oh, suddenly there's more tension on the tendon. It's not that there's more tension, it's just that because we've gotten to a place where now part of the tendon isn't working properly. Now what we actually see is that the tension within that Golgi tendon organ actually dramatically goes up, and that causes this kind of strength gap is what we call it. You'll see this in an athlete if you take an athlete who's got, say, shoulder problems and you have them do a nice slow push-up. What you're going to see is one side is going to drop really quickly, and it's usually the side, their throwing side or whatever, because they've done something to the tendons in there. If you get to the right angle and you get the tendon so that it's now going to need to get load through the injured part, as you can't get load through the injured part, suddenly more load goes through that healthy part. That gives us a signal through the Golgi tendon organ that load just went way up, and you're going to get this feedback inhibition of the muscle of the agonist muscle, and that's going to give us this strength gap. So that's how we're going to look for it, and that's what a lot of the movement screens are trying to do. And a movement screen, what you're doing is you're going through a movement, but you're going through it slowly, and a lot of times you're going through it eccentrically, or you're going into it in an eccentric manner. And as you go into it, what's going to happen is there's going to be a period where if you do have an injury, you're going to drop down or you're going to stop because everything is structured to prevent load from going through that part of the tendon. And
So, yeah.
go
So,
ahead.
does that mean like if we do shit, we can easily look at or easily find it out with look at maybe strength training and there's like I know this asymmetry comes with different reason, but if they used to have like good posture, they used to be like the weight distribute is like perfect. They used to be. And
Yeah.
there's suddenly they have some asymmetry. Maybe that's an issue.
Yeah. So the asymmetry can easily be from a tendon problem. You also see it if you change the mechanics. So if you've got jumpers who suddenly don't jump through the knee, but now are jumping from the hip, you know that what's happened is that when they go down, and you'll sometimes see this in basketball players who have patellar tendonitis, what happens is that their shot comes up short a bunch, because what happens is that they're going down, but they're not going down as far as they normally go down for their jump shot. So they're going to do a decrease, they're going to come up and they're going to shoot, but because of the patellar tendon pain, they're not going to go down as far from the legs, and they're going to not get as much force from the leg. And so the shot comes up short. So you can see there's a number of different things that you can see, but it's really easy, or it's not really easy, but in a lot of cases, what you'll see is if you've got people who can go and you can have them do a movement slowly, and there's always a spot where you can see a little shift, or you can see that little catch, that's usually where the tendinopathy is really being loaded, or should be loaded maximally. And so what you're getting is you're getting this kind of force hole, or this strength deficit that comes in a specific location. And that's really where we're getting load, where we're trying to get load through that injured part.
So does that slow eccentric movement like also like the body weight eccentric also works?
Absolutely. So if you're going in and you're going to take people and you're going to do, say a lunge, you can do a step back lunge, and okay, you're going to go slowly into it, and you see people that suddenly their movement is such that their hip hitches, or their shoulders shift. That's usually telling you that there's some sort of weakness within that system, and that system isn't it's not usually muscular based, because the muscle is pretty much pulling. These kind of hitches happen when there's inhibition, that's basically a neural inhibition a lot of times. And a lot of that is coming from a signal is coming from a Golgi tendon organ.
Do you have like your own way to assess athlete if an athlete come to you, or just like you mentioned, just go through maybe if it's basketball player, they just go through a bodyweight squat, a split squat. If it's a baseball player, we just go through like push up or pull up. Or do you have your own like certain systematic assessment?
I haven't worked that clinically in this. So we're starting to do more clinical work, where we're doing more human clinical trials. So we're doing, like I said, the rock climbing one is a retrospective study, but we're going to do a prospective study as well, where we take them and we assign them different groups. All of those things are going to incorporate measures of tendon pain, and measures of tendon function. So, but right now we don't have specific programs, but that's where, you know, that experience from strength coaches is really useful, because they know how somebody should move. They know their activity much better than I'm going to know it as a researcher. And so they can design something that's going to test the structural, the movement pattern that they're looking for. And so I usually rely on those kind of experts for that. And I try not to say, look, this is the only way to do it. There's lots of different ways to do it. There's lots of people who have great experience, much more experience than I who do it a lot better than I do. And I'm going to rely on their expertise for that.
Cool. So this year there's a lot of like Achilles tendon injury in NFL, and like coaches, therapists are discussing about this. So what are your thoughts on like there's so much, especially this year, there's so much people talking about it. What are your thoughts on this?
Yeah. So again, it's always a difficult question. And a lot of people think that, oh, we're getting a lot of Achilles tendon problems. So what we need to do is we need to stretch the Achilles more. Uh, and I always remind them that the highest rate of Achilles tendon rupture in the NCAA athletics is actually in women's gymnastics. There is not a more flexible, more passively compliant athlete in the NCAA than a women's gymnast. They have much better flexibility and much better range of motion in the ankle than any NFL player. So that's not the thing to do. And so what tends to happen is, again, most of what we do and most of what happens is we're going to look at two different stimuli that come in. You've got your gameplay and your practice stimuli. And for the Achilles, it's all going to be dynamic movements, especially in the NFL. Now, what you're going to do is you're going to then come into the second stimuli, which is the stimulus in the gym. What kind of stimulus are you getting in the gym? And a lot of times, what's happening in the gym is we're still doing dynamic moves because we are doing all of these moves because these are the high performance moves. So I'm going to have you do fast moves at a low weight. You're getting two stimuli that are both going to be driving that tendon stiffness. Okay, that can be okay, but you need to have a really good balance between muscle strength and tendon stiffness. And if all you're doing is fast movements, dynamic movements, really high velocity movements, your muscle strength relative to your tendon stiffness is going to go down. And I don't know, I don't have firsthand knowledge as to where these Achilles tendon problems are happening. But a lot of times, what you're going to see when we're doing lots of very fast movements, only fast movements, now what happens is the tendon isn't stretching as much and the muscle has to stretch more. And we're going to get it towards the muscle end of the tendon, becomes where we get these ruptures. Then you get the other option, which is that people have heard some of the stuff that we talk about. No, we need to load tendons by having 30-second holds. Okay, that's great. 30-second holds, but if all you're doing is 30-second holds, especially in the off season, oh, we're going to do long, heavy holds. Now what's happening is the muscle is strong, the tendon is really stretchy. But now when we go out and we do high velocity movements, now what happens is the tendon is going to stretch a lot further. And so now we're going to get more mid-substance of the tendon issues. And so again, this is why it's really important to combine slow, heavy moves with short, high velocity moves. Because if we're focusing only on one, because we're trying to decrease muscle pulls. So we're trying to decrease muscle pulls. Classic example is the hamstring. Okay, we're going to try and decrease muscle pulls. We're all going to do slow, heavy eccentrics. We're all going to do Nordics. We're all going to do this stuff. What happens then is that all we're doing is we're shifting where we get the injury. Instead of now getting a hamstring problem, now what we're doing is we're getting ACL ruptures because the hamstring is really important for stabilizing the knee, preventing anterior movement of the knee. But if we're now jumping and turning and we've got a really compliant tendon on the hamstring, now what we're doing is we're jumping, co-contracting the quad and the hamstring, but the quad is now super stiff relative to the hamstring because the hamstring, we've been doing all these slow eccentric loads. And now what's going to happen is the quad is stronger, so it's already going to anteriorly pull the tibia. And so now what we're getting is we're getting more ACLs. This is again why we need to shift from understanding, look, it's always a balance. We're going to have to combine these two types of movements for our systems to work. We also have to look at which athletes we have. If I'm working with women's athletics, I'm not loading the hamstring the same way as I'm loading the hamstring in men's athletics. That's simply because estrogen decreases the stiffness of tendons and ligaments. The result of that is that women get 80% fewer muscle pulls because the tendon isn't stiffer than the muscle is strong because the tendon is more compliant. But as a result, they get 4 times more ACL ruptures. So, where in men's sports, I would be doing slower moves on the hamstrings to decrease muscle pulls. In women's sports, I am going to do faster moves with the hamstrings so that I can decrease the knee laxity. All of those things coming together into a structure where I can say, look, this is what they're getting on the field in practice. This is what I need to supply them in the gym. So if I have a football player who's going through 40-mile-an-hour car crashes 40 times a game because they're going into tackles and I don't need to give him high velocity movements in the gym. I need to do heavy, slow, some eccentric or some isometric work to make sure that the health of that system is as high as we can get it. If I've got a swimmer who never ever goes through a body weight level of impact, now what I'm going to do is I'm going to increase the velocity of movement in the gym. I'm going to increase because they're doing all these movements, but there's never a high velocity jerk, except maybe when they have a big paddle on their hand, and that's when they get their shoulder problem. Because now they go into the catch, and the catch, because they have a paddle, the catch is a bigger force. That's the only time they get any jerk, any high velocity eccentric move. And so in that situation, I'm going to have to in the gym provide eccentric load, provide plyometric load. Most athletes are going to be between those two extremes. And so what we're doing is we're trying to titrate how much of the heavy, slow, isometric or heavy strength training with how much high velocity movements we're doing. And if we can get that balance right, we're going to have healthy, strong, high performance athletes. If we get it wrong, if we shift it so we've done too much heavy, slow work, now what we're going to do is we're going to get tendon problems. If we shift it wrong so that we've got too much high velocity work, now we're going to get more muscle pulls because the tendon is going to get stiffer than the muscle is strong. So as I look in what's going on and where these injuries are happening, I can realize, oh, you know what? My training is contributing to that. So this is how I need to change my training. And that's why it's super important for the S&C coach to sit with the coaches, the coaching staff. I need to know what they're doing in practice. I need to know what their goal is. Is this a high performance week, or is this we're playing the bottom team and we're just going to try and do this as a kind of training stimulus? I need to know those things because if I'm programming in the gym and I have no idea what they're doing out on the field or on the court or wherever they are, now what we're going to do is we're going to get an athlete who is imbalanced. And that's when we get into injury problems. And so a lot of the injuries for Achilles are probably the result of that we've imbalanced the training. We've biased the training either towards too much heavy fast or heavy light fast movements, which is usually what happens in football, or we've gone through an imbalance where we've done lots and lots of heavy slow work to decrease muscle pulls in the future, but we've done too much of that, not enough plyometric work, so that now what we're going to get is we're going to get tendon problems.
Nice, nice. I'm sorry I put you in a hard position to answer that. That's really hard.
Yeah, but it's you also have to combine it with how much inactivity they have.
Yeah.
So all of those things are going to create a system. And so if you look at it, I haven't, like I said, I haven't seen the data from the NFL. But if you look and see where those injuries are occurring, you can trace it back to what type of training could you have done to prevent it. And if everybody's having the same location of injury, that's telling us that our training is biased in such a way as to produce these kind of inequalities within the tissue that are going to result in injury.
Nice, nice. Thank you. So that's basically all the question I have for you today. So for those who are interested in what we're talking about today, where can they reach out to you?
Yeah, so I still will go on to Twitter from time to time, and my handle's at Muscle Science. So that's probably the easiest place. People always the best place always to find information is on PubMed. So the key thing there is that my name is spelled a little bit weird. It's Baar. So as far as that goes, if you just put in Baar space K into PubMed, you're going to get all of our papers where we describe a lot of the stuff that we're talking about here.
Thank
And
you.
all of them should be open access. If somebody looks up a paper and they can't get it for whatever reason, they can feel free to email me and I will send it to them.
Okay.